Ceramic and composite inlays, onlays and overlays. Indications, contraindications to do cusp reduction or to keep uncovered cusps, and many other tips and tricks. Hello dear friends and colleagues, and welcome to our webinar that is dedicated to ceramic or composite indirect partial restorations like inlays, onlays and overlays. And today we will discuss with you very interesting and practical things like classification, indications for partial ceramic or composite restorations. We will discuss cases where we have to do cusp reduction and cusp coverage, or in some cases we can keep occlusal surface uncovered. We will be talking about preparations, we'll be talking about some clinical tips and tricks like cavity design optimization and material selection, and for sure we will discuss with you a very important topic about biomechanics in order to understand how posterior teeth work and what kind of restorative treatment and material to offer to our patient in certain clinical situations. Okay, so let's start, and let us start with biomechanics, because it is important to know that posterior teeth have to be restored not just to make them more aesthetic, but also to integrate them into the functional envelope. And we have to understand how do these teeth work in a heavy functional environment. This slide from Pascal Manier, and you can see biomechanical properties of sound tooth structures. We have to know these numbers because we have to understand when we have any type of defect, we actually are replacing enamel and dentin when the enamel and dentin were affected by caries defect, for example. And you can see that enamel and dentin has absolutely different physical properties, especially if we will take a look into modular elasticity, the parameter that is responsible for stiffness of the tooth. And obviously now we can understand when we have to restore defects, we cannot rely only on one type of material, because when we work with composite, for example, or just with ceramic, we are working with one biomechanical substrate, and we have to integrate this substrate into the biological environment, which is different. Okay, let us take a look also into that very important topic, like different types of caries defects and how do these defects affect stiffness of coronal part of teeth. For example, the articles here that I'm referring you, they are pretty old. They're from 1989 and 1981, which is pretty old, but still this information is very important and gives us a big value to understand some functional parameters and features of teeth. So when we have just simple class 1 cavity defect, we can see that the tooth may be affected from 14 to 44%. I mean, stiffness of teeth can go down to that numbers. 44% is pretty big number, and that's why we have to understand that not every single class 1 defect can be restored with direct restoration. Sometimes we have to do indirect restorations even with class 1, and we have to be very careful with case selection. Let us take a look on this graphic information, which shows us also stiffness when we have class 1 defect, and also Caspal deflection. So you can see stiffness goes down and Caspal deflection goes up. Caspal deflection is the one when we have any occlusal force, the walls and cusps may deflect, and that in some cases may lead to create a crack line, especially from mesial to distal area. And we can see such clinical signs in cases when we have class 1 amalgam filling, for example, or sometimes even when you have class 1 composite filling, which is not bonded properly. I would like to make some highlights at this moment. When we have amalgam filling or cement filling or composite filling that is not bonded well, these restorative materials they work separately or they work apart from the whole biological substrate. The goal of restorative dentistry is to integrate our artificial restorations into biological and functional environment, and the main goal is to have restoration and tooth working together as a complete object. Okay, but when restoration is not bonded properly, it works separately, and it may cause or it may lead to have these clinical sites like a crack lines, like you can see on this on this scheme. And let me just show you a clinical situation that may be very often in such clinical cases. Look, amalgam filling, class 1, and what we can see here, we can see that distal crack, the distal crack. And when we have that cases and we are going to restore that teeth, we have to be very careful with diagnostics. So before starting doing any restorative treatment in such a cases, when you can see caries defect or big filling, amalgam or composite, doesn't matter, and you can see these crack lines, the first option, the first spot or first moment that you have to take into consideration is to make vitality test. Okay, you have to understand if tooth is vital or not. If tooth is vital and there is no symptom, the case is pretty favorable. Like in this case, the tooth is vital, no symptoms, patient just wanted to replace this amalgam filling, and I saw also some secondary caries underneath. So we started this case with removal of this amalgam filling, and then once I removed amalgam filling and I removed caries defect, I started to evaluate biomechanical environment to understand what type of restoration and what type of, let's say, material to use in such clinical case. First of all, I'm taking into consideration thickness of the walls that are surrounding the defect. In our case, the thickness of the walls pretty enough to resist occlusal forces. Okay, another favorable feature in that clinical situation is that tooth is vital. Another very favorable feature that gives us good and favorable prognosis is that there are no symptoms. Okay, and number 4 site that I am taking into consideration is occlusion. This is not bruxist. This patient is not clencher. We don't see any varying facets. That makes us to make a conclusion. The case is easy for us, the cavity is small, and we can do any type of bonded restoration, even direct. If you will select in such a case direct restoration, you have to follow adhesive protocol in very precise way, and also you have to follow incremental technique to compensate C factor. Let me give you insights in terms of case selection and technique selection, because this information is very important, and I would like you to pay now attention to the words that I'm going to say to you, because this information is very important. So, when we have any type of defect, caries defect or old composite material or amalgam, doesn't matter, and we are about to do new restoration, we have to make proper case selections in terms of providing technique of restoration, direct or indirect, cusp reduction or not cusp reduction. Okay, so the first group of cases are easy ones. The easy case is when tooth is vital, when the defect is small, when there are no symptoms, and functional and function is okay. These are sides of simple case. Another group, difficult case. The tooth is non-vital, or if tooth is vital, the occlusion is not correct, bruxism, clenching, cracks, and we have a so-called cracked tooth syndrome. So in that case, you have to be very careful in terms of material and also technique selection. And another thing that we have to take into consideration in that second group is the size of defect. Okay? So every single time before I do anything, I'm evaluating all these parameters, and then I have in my mind the way to make a clinical performance, restorative clinical performance, and to select proper technique and way. In this case, as I mentioned before, no symptoms, small cavity, normal occlusion, vital tooth. So we can go into incremental technique even though we have this crack line. If you will do proper bonding procedure, that restoration may work many years and everything will be fine. Okay, so you can see steps of my rehabilitation using composite. This is just post-op, another post-op once Robinam was removed, and here I have a picture of 4 years follow-up, but this case was done more than 4 years ago. I think nowadays we have about 7 years of follow-up and everything is fine. The patient is in touch, but he's in another country, so I cannot see his teeth like you can see on that picture. Okay, so that is fine. I hope that this information is clear for you regarding case selection. Then let us go more into difficult clinical conditions like class 2 caries defect, and you can see that class 2 may reduce from 20 to 63%. 63% is almost pre-implantological treatment, and we have to be super careful in such clinical cases because the stiffness of teeth will go down and Caspal deflection will dramatically go up, which may lead to create not just a crack line, but also it may lead into the fracture of teeth, especially our favorite ones, upper premolars, when we have class 2 caries defects. And sometimes we have clinical cases when patient comes without palatal wall, for example, after our treatment with composite filling, for example. So in this case, when we have that class 2 caries defects, the problems from inside may lead not only for mesodistal crack formation, but also it may lead to have so-called oblique crack underneath to any of the cusps. So we may expect breakage of any of the cusp separately. Material selection and another clinical information now that I'm going to share with you is taken from my mentor, from Didier Dici. I think that he is one of the best in restorative dentistry, and his classification, clinical classification of defects, is very simple to understand, and it gives you a lot of answers to select proper technique of restorative treatments. So we have small cavities or small medium, we have medium large cavities, and we have also extensive cavities. We have cavities below cementum enamel junction, and we have cases above enamel cementum junction. Okay, as I mentioned before, the ideal situation is to create or to integrate our restorative material into biological and biomechanical environment. That's why we have to select material properly according to the amount of defect that has to be replaced. How do we actually define which cavity is small, which cavity is medium, large, or extensive? It's just it comes from evaluation of the thickness of sound tooth structures around the defect. So when we have defect surrounded by tooth structure that is more than 2.5 millimeters, it's easy. It is small or small medium cavity. If the thickness of the walls around is just 1.5 millimeter, it's medium large. And in this case, you have to be very careful in terms of material and technique selection, because when you have, for example, endodontically treated teeth with such a defect, you have to be double careful because of the stiffness of the tooth. And extensive. The extensive one is when you have defect that is surrounded by the walls that are thinner than 1.5 millimeters. And in most of the cases, we will have to do cusp coverage restoration for that clinical situations. Let me show you some biomechanical parameters of materials that we are using nowadays to restore teeth. We have composite materials. Now, composite material is easy to be to work with, and also it is acceptable, accessible, but the modular elasticity of composite is pretty much the same as dentin. It's not like enamel. And how can we know? Why do we need this information? The modular elasticity, what is that? For example, you have tooth with filling, okay, and there is occlusal force. Occlusal force comes to, actually it goes to restorative part, to the surface of your restoration. And if the modular elasticity is low, this material accepts occlusal force and then transfers this occlusal force to underlying structures, and it may lead to have these crack lines under the fillings even, or cusp breakage. Okay, enamel is pretty close to ceramic, and ceramic is more resistible for that occlusal forces. We have to keep this in our mind, and we have to know that, especially when we are discussing anything with our patients, and we say that in this case you have to go for ceramic restoration. It's not because ceramic restoration is more expensive that some patients used to think that dentists want to earn money just restoring patients' teeth. We have to be clear with our patient, and we have to explain that we are restoring defects, and your tooth has enamel and dentin, and each structure has its own biomechanical parameters, and we have to select material with similar biomechanical features. Otherwise, you may lose your tooth because of the restoration. Okay? Let us take a look on this scheme. For example, when you have small medium cavity and there is any restorative material, there will be occlusal force that will be completely taken into sound tooth structures. So basically, in such a case, you can use anything you want. Okay? Then, medium large. In this case, restorative part will accept a lot of occlusal force. And if this is difficult case, you remember, right? What is difficult case? Non-vital teeth, parafunction, bruxism, clenching, cracked tooth syndrome, for example. Okay, so in that case, it's pretty dangerous to work with composite material or to make so-called inlay restorations, because material will accept occlusal force and it will transfer this occlusal force to peripheral aspect of teeth, and this case may lead to have this crack or towards the cusp, for example. Extensive, it's a danger zone because almost all occlusal force will go into the material, and in some cases it may lead to have breakage of the wall completely. And I don't know if you have these cases, but I had few cases when I restored, for example, our favorite teeth, upper premolars, MOD, with composite material, and then after a while patient came back and said, "Doctor, something happened with my tooth. I heard some crack, but I was eating just the bread, nothing super strong, and then I see that with my tongue I feel that there is something missing." Then you take your intraoral examination, and then you see that there is no palatal wall at all. There is a vestibular wall, but there is your filling composite, and there is no palatal cusp. In such a case, you say to your patient, look, the filling that I placed is very strong. It is stronger than your tooth, so you were very right to spend money to that expensive composite material, because see how strong it is. But the problem is that we did not select proper technique of restoration. It is not because of a brand of material. It is incorrect restorative technique. In such a case, when you have thin walls, when you have other things that are making case to be difficult, like endodontically treated teeth, crack line with symptoms, parafunction or whatever, you have to do actually we have to reinforce teeth with our materials and with our technique. So class 2 again reduces a lot. Caspal deflection increases by itself, and imagine that you have material that transfers that forces to peripheral and will help to deflect more. Okay. By the way, how do we know the size of cavity? I would suggest you to have in your office caliper or micrometer that you can use to measure the thickness of the walls, then to make a conclusion about thickness and to select the proper way to do cusp reduction or not to do cusp reduction. Now let me give you some numbers, okay? When you have easy case again, when you have, let me go back to that classification. Easy case is then when you have more than 2.5 millimeters, okay? Actually it's a small medium cavity, sorry, it is small medium cavity, but the case is easy, which means the tooth is vital, no problems with function, everything is correct. So in that case you can do direct composite restoration, okay? But when you have medium large and the case is easy again, vital tooth, no symptoms, no cracks, normal occlusion, so medium large in such a case still can be restored with incremental direct technique. But if case is difficult, endodontically treated teeth, okay, or crack or whatever, in such a case my personal preference is to go for cusp reduction and cusp coverage. So easy case I can keep without cusp reduction and cusp coverage when the walls are not less than 1.5 millimeters. But when we have difficult case, the minimum thickness of walls that I can keep uncovered is 2.5 millimeters, okay? But if there is a symptom and cracked tooth, so I would go definitely in such a case for cusp reduction, even if walls are pretty thick. So every single time when we have to restore any tooth, we have to evaluate many aspects to make a conclusion what kind of technique to use and what kind of material to use. Okay, so let me just give you an example. For example, we have tooth with such a defect. The cavity is pretty thin. The cavity is big, the walls are thin, and now we have in our mind that we have to do cusp reduction and cusp coverage restoration. Now the question is, how far or how deep we have to cut the cusp? How much we have to cut the cusp? 1 millimeter, 2 millimeters, 3, 1.5? This is the question. And there is an answer. Actually, there are few answers. The first, we have to take into consideration recommendation of manufacturer regarding material that we are using. For example, if you are going to restore that teeth with Emax, we have to see how thick restoration should be on occlusal area, on occlusal zone, to resist occlusal forces. Okay, so for example, in instruction you may read that Emax has to be about 1.5 millimeters. Okay, so now we have to give this space for that restoration. So basically we can take our depth marking burr and let's say we prep 1.5 millimeters here. 1.5. We reduce 1.5 and we give this 1.5 for ceramic. So it will be pretty thick. Ceramic itself will be pretty thick to resist occlusal forces and everything should be okay. But another thing that we have to take into consideration always is the thickness of that remained walls. Okay, and then we go into other parameters that we have to evaluate: vitality, symptoms, occlusion, etc., etc., etc. So if here that I mark with green will be about, let's say, still 1.5 millimeters the thickness, but the case is difficult, okay, the case is difficult, I would have to prep more. I would have to prep up to this point, for example, where the thickness of wall for difficult case will be about 2.5 millimeters. I have to. It's not your fault that patient came with that defect. You have to do your best in terms of biomechanics to integrate this restorative part into the envelope of function. Otherwise, you may lose the tooth, not just restorative material. Okay, so sometimes we have to prep that much. Sometimes we have to prep up to this area. Okay, so that everything will be covered and you will have enough thickness of the walls to resist occlusal forces, not just because of material that we are using. Okay, so with that, two things you have to keep in your mind: the thickness of material that is recommended and also the thickness of the walls that can resist occlusal forces. Okay, that is important. Then another thing that we have to know also, for example, we may have enough thickness of walls after preparation, but the depth of cavity is pretty deep. The ideal situation is when the width, the distance between walls is the same or bigger than height of the wall. Okay? In this case, like you can see here, that distance, which is yellow, is more narrow, is smaller than the height. But in such a cases, when you have a high walls and a very deep defect, there is a so-called lever effect that may propagate some cracks. Okay, and you have to be very careful in that term. So what we can do in such a cases, for example, we have a defect, we prepped, we got enough thickness of the walls, but the height is too much. For example, for endodontically treated teeth. If you will follow classic approach, you will have to prep more, okay, to decrease height of the walls, or, which is better nowadays, you can follow so-called cavity design optimization concept by Didier Dici. Instead of cutting, you can add, you can do some composite adhesive build-up. And by composite build-up, you may decrease the distance, okay? And in this case, we have to replace dentin, right? And we are working with composite, which is pretty similar to the dentin by biomechanics, okay? And if we follow properly adhesive protocols, everything works perfectly, okay? One clinical tip that I would like to share with you regarding the amount, regarding the height of the build-up itself. How far we have to go. Because, for example, let me just draw here, that will be our artificial restoration, okay? So we can actually keep it like it is. For example, it will be like endocrown, okay? Like an endocrown. But I don't like to use endocrowns, to be honest with you, because of a few reasons. The reason number one is that I personally prefer to work with light curing materials, like curable materials, like curing cements. In this case, I keep in my mind that I can light cure through ceramic, which is about 2.5–3 millimeters. So I can build up with composite. I can build up with composite here to keep about, let's say, 3 millimeters of ceramic that will go over, and then I can light you through. So that is the thing that I'm using for my overlay restorations. And with this cavity design optimization technique, you are actually getting many benefits. You prep less, you close undercuts, because you will have always undercuts when you have caries defects, and also you are doing immediate dent sealing, which increases bonding strength. Okay, so perfect. Let's go next. Let us see what kind of material can be used for indirect restorations for posterior teeth. Composite material. Composite material is easy to be used. It is accessible. It is simple to fabricate. You can do it yourself even without dental technician. You can do it chair side or you can do it on the model. Relatively strength, gentle to opposite substrates like to antagonists, aesthetic, precision, and bondable, which is very, very nice. Indications. You can do onlays, you can do overlays for vital teeth, cracked tooth syndrome, lateral, okay, but cracked tooth syndrome, MOD, is pretty risky because of low module of elasticity. That's why. Endocrowns also under question. I'm not trying to say that is contraindicated, but in the case when you do crown, endocrown, for example, or crown, it's better to go with ceramic material because we have ceramic materials in such cases is more researched material, and we have long-term clinical cases proved that ceramic works than composite. Okay, non-vital teeth under question and crowns also under question with composite materials. You can do that, but it will be your own risk because still material has very low module of elasticity. Regarding ceramic, it is strong, high modulus, surface pretty hard, very resistant, aesthetic, precision, bondable, which is perfect, and you can use ceramic in every single case you want. Okay, for onlays, overlays, cracked tooth syndrome, MOD, endocrowns, non-vital teeth, crowns, fragilized teeth, as you wish. This is what I was trying to say. When you have composite, okay, you have composite, even with Cusp reduction, the low modulus of elasticity may bring the occlusal force to peripheral aspects, and theoretically it may crack. Okay, when you have ceramic, it's better, okay, because of high module of elasticity. And there is a very interesting and very important clinical tip on this slide that you have to pay your attention to. When I have endodontically treated teeth and the walls were pretty thin, so I got my 2 millimeters, then I do my butt joint preparation for overlay, but butt joint will be not straight like this. It will be driven more to peripheral aspect of tooth, buccal and lingual, that way, okay, that way. So when ceramic will go to peripheral aspect, and if there will be still Caspal deflection from inside, the ceramic on periphery will block the tooth from outside, creating so-called ferrule, external ferrule effect, which is really good to save a lot of teeth affected by endodontic treatment or maybe by cracked tooth syndrome as well. You may find very interesting article by Didier Dici in internet, PDF, I think it is available in internet, and you may read a lot of useful information about restorations of endodontically treated teeth. Okay, types of restorations. Let's go into that clinical part. So types of restorations. We have inlays, we have onlays, we have overlays. What is the difference? The inlay is that type of restoration without any cusp coverage. So basically it looks like normal filling. Okay. Onlay. The onlay is the type of restoration when you have to cover some of cusps but not all of them. Okay. And overlay when you cover all cusps. Okay. This is overlay restoration. Regarding preparation, the preparation is relatively simple, okay? Relatively simple. You have to take into consideration pathway of insertion and to create slight divergent walls. In such conditions, the pathway, the insertion will be easy. The insertion will be passive if you will have these divergent walls. When you have undercuts inside, you will block them with composite, which is very, very nice. What else? You have to open interproximal box. It will be easier then to take impression, to isolate, to bond, and to remove excess of your luting material. Okay? Nowadays, when you work with bonded materials like ceramic or composite, you don't need to do any of retentive form of preparation. You don't need to make any boxes inside. So basically all your preparations will be defect oriented. You have to take into consideration thickness of walls to make a conclusion to do cusp reduction and cusp coverage or not. You have to make some divergency, and you have to go to open interproximal box. This is what you have to work with. What else? I would like to share with you some steps or some rules for preparation. The planning of preparation has to be done before you take burr into your hands. Nowadays we have a very good possibility during primary consultation to make documentation with the photo cameras or videos, and then we can understand and examine this information and get a lot of useful practical clinical information, like preparation designs, for example. We can plan our preps in advance. Then if we go into the classic preparation, we have 3 phases. The step 1 is initial prep, where we're creating space for ceramic restoration, removing caries, open box. Okay, we can do slight divergency during this step, and we work with a high speed. The speed will be more than 100,000 RPM. Then we go into main step with red diamond burr. We create main design of our preparation, very smooth transitions, positive angles, and so on. And finishing stage, when you can use disc strips, rubbers, and hand instruments, for example, to create a smooth internal surface and very smooth and very precise margins of your preparations. If you want to know more, and if you want to upgrade your skills actually and knowledge in specific topic of preparations for ceramic inlays, onlays, overlays, and veneer lays, I invite you to participate in our online workshop, which is called Partial Ceramic Restorations. You may find information about this online workshop on our webpage, which is online.belograd.com, and you may participate in very advanced and very precise and didactic event, and you will see step-by-step preparations. I will be not talking to you, I will be showing you things, and you will see everything by yourself from multiple cameras in very educational and very advanced way to learn and to understand the process. So it will be similar like over-shoulder course for you, okay? And I'm pretty sure that you may find a lot of practical things that you may implement in your daily basis immediately after participating, okay? So let's go next. Let me show you a classic inlays, overlays, etc. case about this. So we have initial situation like that. You can see old composite fillings, and what else? We can see crack and symptoms. This tooth is symptomatic. Patient feels uncomfortable with chewing, and some cold problems that he feels in his tooth. So in that case, we have difficult situation, right? And we have to be super careful in terms of material selection and technique selection. So we start our preparation. Okay, you see that we made cusp reduction, and the cusps are very thick, but still we have to do that. Otherwise, if I will just do direct composite restoration, considering the fact that this tooth is symptomatic, I may lose this tooth afterwards, okay? It is not the same as I showed you with, let me go back. It is not the same as this one. It is not the same. This one that you can see right now on the slide is asymptomatic, okay? Vital and asymptomatic, and it is class 1. But the one that I'm having here is way difficult and way different, okay? So then you can see we made opening of the interproximal walls, we made divergency, and we have still undercuts because they were Caries defects. So we made this CDO, which is also can be called like a immediate dentin sealing as you wish, okay? We have our ceramic Emax overlays and inlays also, and we are going to bond. This is another appointment. We isolated for adhesive cementation of these partial ceramic restorations. Few tips regarding bonding. You have to have sandblaster to sandblast these composite areas, because sandblaster will increase bonding strength to that composite substrate, okay? And then you bond your ceramic with your regular protocol. So we have them bonded, okay? Another type of restorations that we have, so-called trendy restorations, like tabletop restorations or occlusal veneer or veneer lay restoration. And at this slide you can see that is occlusal veneer. The surface is plain, okay, no retention, nothing. And veneer lays are here. Veneer lay we do when we deal with aesthetic and we need to change the color. That's why we go into buccal surface because of aesthetics, okay? So it's easy. Let me show you case. We have aesthetic rehab case, and molar tooth was exposed during smile, so we decided to change color on this tooth as well. After caries removal, everything looks not bad, by the way, and we can do direct restoration here, but this enamel is unsupported, so the thickness of these walls were less than 1.5 millimeters, okay? And that's why I decided to make slight cusp reduction exactly here. And then I removed this, I dealt with undercuts with a composite material. This type of restoration can be called as veneer onlay. Why onlay? Because I did not cover palatal cusps, both on molar and premolar. On molar, let me show you the margins, okay? So this is proximal margin, this is buccal margin, everything is in enamel, this is very important. So here is my margins, okay, in enamel, and dentin was blocked with composite. Very favorable situation for bonding, okay, and very predictable situation for long-term result. So here are these restorations after bonding, and here you can see occlusal view for rest of teeth, and this is her smile frame. Then let me show you one more case, one more very compromised and very, how to say, discussable case, full mouth rehab case, when we deal with occlusion and aesthetic. And I will just show you a part of this case. Here is the lower quadrant, right quadrant, and you can see multiple defects, a lot of composite fillings, the color of teeth is not okay, and so on and so on. Let us calculate, by the way, how many fillings you can see on this tooth, on a first molar. So we have one from lingual, right? So here is one, here is another one, okay, then we have something here, and then we have something from buccal side. You can see a lot of composite fillings together separately on that tooth. So that's fine. I removed this composite, I removed secondary caries, and I saw that substrate. The tooth is vital, by the way. The tooth is vital, okay? And the question is now, how can we restore that tooth? It is absolutely non-retentive. And another thing that we have, another problem that we have, take a look at on the depth of the defect in comparison, in relationship with gingiva. So here is my tooth, and here is the level of the gum, okay? So it is subgingival from the distal lingual aspect. It's not easy. It's not easy. So how do we restore that one? If you are in adhesive dentistry a few years and you are following modern protocols of restorative and adhesive dentistry, it is not a question for you. But if you, let's say, more in old school dentistry, or maybe you do not have enough knowledge in adhesive dentistry, that may be a question. And I can say that if that case would come to me when I was just a student, for example, or maybe a fresh graduated one from university, with the knowledge that I got from university, probably I would make endodontic treatment here, post and core and crown, like an old school classic approach. But nowadays we can just restore these teeth like they are. The only thing we have to isolate to have a very nice environment for bonding. Then we can do immediate dentin sealing with resin materials, with composite material. We do IDS. You know that there are many benefits of IDS. It increases bonding strength. That is the main benefit that we can get to our restorations. Okay? There are many articles that are not connected to Pascal Manier, because Pascal Manier is the author of the technique, and there are many articles that are not connected to his name, and many articles that show you that IDS increasing bonding strength, which is very nice. The only thing that you have to follow properly IDS, you have to follow properly your bonding procedures, and then you may expect long-term survival rates for your restorations. By the way, we have some videos about IDS on our YouTube channel. There is an interview with Pascal Manier about IDS, and there is another educational video about IDS from our side. So you just go to our YouTube channel, go to videos, and search for that videos. Okay, so we made this IDS. We light cured through air block. This is not necessary step, by the way. The only thing that you have to remove this oxygen inhibited layer before you will take impression and make provisional restorations. So you can see straight after IDS, this is lateral view. Here is the view of occlusal view for the rest of teeth, because we, as I mentioned, made here full mouth rehabilitation. Here you can see before cementation, isolation again, sandblasting, it is important. So let me give you some tricks and tips about bonding to composite. You do micro etching, which is sandblasting. You can use aluminum oxide or you can use silica particles. Then you may use silane, the same silane that you are using for ceramic restoration. The silane will give you chemical adhesion to glass particles that are in composite material, like a filler. And then you go with your regular adhesive. So you do etching of enamel, you rinse, you dry, then you do, look, the sequence. You do sandblasting, okay, you clean, then you do etching of enamel, then you can etch also composite just for cleaning, then you rinse, then you dry, and you may apply silane just on composite, then you wait, and then you apply your bonding to enamel and to that composite, and then you go with your cement and you bond your ceramic restoration. And then you go, and then you have your result like this one. In this case, we have to work with dual cured materials because the thickness of that overlay was pretty thick, and I was not able to light cure through efficiently. So you can see now before and after rehabilitation of that patient. Okay, so as you see, guys, nowadays we have a lot of possibilities with bonded ceramic or composite restoration to restore and to rehabilitate posterior teeth. And I would like to make some conclusion because we are about to finish our webinar, and I would like to make some conclusions that just to refresh and to remind you what we were discussing here. So first of all, you have to be very careful in case selection. You have easy cases, you have difficult cases. Then you have to understand classification of cavities, small, medium, large, and extensive, to make decision to do cusp reduction or not to do cusp reduction. And also you have to take into consideration materials in certain clinical situations, ceramic or composite. Ceramic works in every single case, composite works in certain cases because of low modular elasticity. You have to understand how to prep teeth properly in order to get perfect fit of your restoration. You have to consider thickness of your restoration to make enough space. You have to open in the proximal box. You have to think about divergency of the walls, and you have to avoid negative angles, especially in proximal areas. If you want to learn more about preparations, again, I invite you to participate or to attend our online masterclass, online workshop about preparations for ceramic inlays, onlays, overlays, and veneer lays that you may find on our webpage, online.belograd.com. So I hope that this webinar was useful for you. I tried to give you a lot of tips and tricks, clinical information that you may apply on your daily basis. I wish you to be healthy. I wish you to have dental force, and I hope to see you soon, my friends. Bye-bye.